All right. So let's speak about thyroid orbitopathy. So it can cause painless proptosis. It can also cause painful proptosis as well if you have inflammation. You can be euthyroid or hyperthyroid and hypothyroid as well, especially if you've had your thyroid removed because of previous high hyperthyroidism. And it essentially involves deposition of glycoprotein in the extraocular muscles, but which spares the tendon. You can also have it mainly affect the fat, and in that case, your extraocular muscles will look relatively normal, but it can affect your muscles, mainly as well. So you can have the kind where you don't have a lot of inflammation, but you have a lot of fatty involvement. So you'll only have proptosis and eyelid retraction, or you can have the inflammatory kind, where your extraocular muscles are involved more, and you have a lot of inflammation, extraocular muscle restriction, and those are the patients that are at high risk of optic nerve compression. So arm slow is the mnemonic. So the most commonly involved muscle is the inferior, followed by the medial, then superior, then lateral, and then the obliques are rare, but they occur. But the most important thing about that is that idiopathic orbital inflammation often affects the lateral rectus. So when you have isolated lateral rectus involvement, you have to think orbital inflammation as opposed to thyroid eye disease. The other thing is that lymphoma can also affect the extraocular muscles. So we always get a scan on all these patients to see if there's extraocular muscle enlargement, and then we can see if they have what we call apical crowding. So on the coronal view of the on the CT, you can see if the muscles are surrounding the optic nerve. So differential diagnosis is, of course, orbital inflammation, lymphoma, and sarcoidosis too, but it's not very common to have sarcoidosis involving the extraocular muscles, at least less common than these other two. Let's move on. So here you can see a classic sort of tendon sparing involvement, and you can see how much larger this medial rectus is than the lateral. And then as you're going back towards the apex, you can see the optic nerve can get really crowded within these, and you can get optic nerve compression, which is why we then, do orbital decompression to help relieve all that, and we can remove a lot of this bone. Here you can see that same one. So you can see medial rectus is the most involved. So in this patient, the medial is the largest, but inferior is involved as well, and the superior as well, and the lateral rectus looks pretty much normal. So here you can see that there's fat in between, but as you go back to the apex, see there's no fat left. I mean, this is very high risk. So this is a nice place to show where we can do decompressions as well. So you can imagine this bone of the medial wall is very thin. So you can go from a transcutaneous incision right at the medial canthus, or more often now we go transcaruncular, and we can go and we can remove all this medial wall all the way to the back, cut the periosteum, and allow all of this to sort of prolapse out. And you can move the orbital floor as well, so that you can do a combined medial wall and floor, or people often do a combined medial wall and lateral wall, where on the slide before, you see how this lateral wall is quite thick. So you can sort of, if you take out all of this, that'll allow the orbit to expand a lot here. But of course, some of that is away from the optic nerve, but you can remove it all the way back here. So, that allows for a lot of it to expand. We already went through this. And you can do 3-wall decompressions as well. So here, here, and here. So orbital inflammation or orbital pseudotumor is painful, rapid onset. You can have eye swelling and ophthalmoplegia. So this comes on really fast. It's mostly unilateral in adults. In children, it's less common, but it can be bilateral too. So here you see all this inflammation around it, but it can actually look like one solid roundish tumor. So even the differential for a tumor that's causing a lot of inflammation is inflammation itself as well. It can involve any structure of the orbit. The lacrimal gland is very common, but of course, extraocular muscles, it can involve the fat. It can involve multiple extraocular muscles too. And when it involves more than one, then often like you're more suspicious of thyroid eye disease because that's by far more common than this involving more than one muscle. But the main thing to differentiate is that it'll involve the tendons too. But thyroid eye disease or this can both be inflammatory, and so it's hard to tell. But which muscle is involved is very useful. So here you can see that there's more inflammation in the back here, but in general you can have lacrimal gland involvement. Bilaterality in adults may indicate systemic disease, but honestly, if it's bilateral, I'm thinking more lymphoma and Wegener's, or sarcoidosis as well, because orbital pseudotumor is less commonly bilateral. Mostly has T cells in it, and Tolosa-Hunt syndrome is inflammation of the cavernous sinus or the orbital apex. So this is what they're showing here. That's also idiopathic inflammation. It could be associated with the herpes virus, but when it's more in the cavernous sinus and in the orbital apex, that's when we think that it's Tolosa-Hunt. But treatment is still the same. We would do steroids. But of course, you want to rule out infection. So we often end up starting antibiotics too. But then but even for infectious orbital cellulitis, you can give steroids too. So we'll often give both steroids and antibiotics for any inflammation like this, because you can't be sure until some of your lab tests come back. So here you can see there's enlarged extraocular muscles, especially this inferior rectus here, and this could look like thyroid eye disease, but you see like there's some inflammation around it too. So this is a little bit more suspicious for orbital pseudotumor. And yeah, here you can see some more. Here you can see inflammation. So let's talk about some tumors. So rhabdomyosarcoma, it often happens in young children. It can also happen sort of older children, like 8 to 12 years old as well. It's rare in adults. So it's from undifferentiated mesenchyme in orbital fat. It's not from the differentiated extraocular muscles. It's rapidly progressive, but if you catch it, if you can resect it, and now there's great chemotherapy and radiation too, but now survival is much better than it was before. And if you can resect it completely, there's a very high survival rate, but oftentimes we can't. I mean, oftentimes we'll biopsy and we'll remove a lot of it, and then chemo and radiation will take care of a lot of the rest. So we're just going to go through this. So you can see this tumor has eroded the bone. There we go. So both the anterior maxillary wall, the orbital floor. So this is very erosive. And there we see it. So, I mean, this could be anything when you see it, right? But, it's not going to be sinus infection because it's really eroded the bone. So sinus infection can eventually erode the bone too, but then it would look more like this, with this maybe being thinned out with a small gap, but not like this. So rhabdomyosarcoma is more common in the superior orbit. However, the bad kind, the most aggressive kind, which is alveolar, that often comes from the inferior orbit. You can see this is all homogeneous. There's bony destruction. T1 is iso to low, T2 is high, and it's marked contrast enhancement. And then here, so there are 4 kinds of rhabdomyosarcoma. So embryonal is the most common one. Then you can have the most aggressive, which is alveolar. You can have sort of the more benign one as well, with the best prognosis. And then there's another one called botryoid, or like more like grape-like, where it can come from the sinus and then extend into the orbit too. But this looks very aggressive. Here you can see on MRI, it's it's enhancing. All right, so lymphoma. Lymphoma is the most common adult. So it's the most common orbital malignancy in adults. I mean, it's very common. Whenever we see a tumor in the orbit, we always have to, unless it's rapidly progressing or there's a lot of inflammation and it's causing the eye to, shift, that can mean it's some other sort of tumor. But we always think lymphoma first in any tumor that's not causing a lot of symptoms, and it's sort of molding and diffuse. So it's usually monoclonal B cells. It can involve the lacrimal gland and conjunctiva. That's very common. It can be focal or mass-like or infiltrative. So it can be anything. And it's already dense even pre-contrast, but is intermediate to low on T1, intermediate to high on T2. But again, as I said, in terms of the enhancement and all of that, the main thing that we as ophthalmologists look at, or as orbit surgeons look at, is it molding? What kind of symptoms is it causing? Because a very big tumor not causing a lot of symptoms that spread all over the orbit is usually lymphoma. Any other malignancy that's that widespread would cause significant symptoms. So here you can see this is all over, but the patient will probably be not very symptomatic. And it's sort of diffusely involving. And here you can see on the sagittal as well. So metastases are uncommon. So it's less than 10% of biopsied orbital masses. They can be focal or infiltrative as well. They can be anywhere in the orbit. So you can see a lot of this is sort of in common with lymphoma. And so, you can't absolutely know unless they already have a history of another cancer somewhere. So, a lot of times somebody who has a history of lymphoma who then develops something like this that looks a lot like lymphoma, we generally don't have to biopsy it to know that that's what it is. But generally, like if we're going to do radiation to treatment, so the treatment of orbital lymphoma is radiation. That's the treatment of choice. But the radiation oncologist generally wants to have a biopsy before they start radiation. But if you have a history of cancer elsewhere, especially breast or lung, and you see metastases, then, or you see something like this, it's more likely to be metastases. Also, it's more likely to cause sort of mass effect symptoms. Another thing is that anyone with a history of breast cancer who now develops enophthalmos, so what we call serous breast carcinoma, so you can have a fibrotic reaction and you can have enophthalmos. Now, generally, other tumors don't cause this, but prostate cancer can. But generally, enophthalmos due to a metastasis is very suspicious for breast cancer. And other things that can metastasize are, of course, renal cancer as well, neuroblastoma. But they'll usually have a mass effect as opposed to enophthalmos due to fibrosis. So orbital and optic nerve sarcoidosis, I mean, it can show up in different ways. The lacrimal gland is by far the most common thing, but you can have optic nerve involvement, you can have orbital fat involvement, extraocular muscle involvement. Chest radiographs are often positive as well. You can have elevated ACE levels, and on gallium scintigraphy, you can then see like the panda sign we saw before. So MRI of brain and orbits is very useful to see exactly what's involved and what's not, because if you remember, the optic nerve and orbital apex are much better seen on MRI. This can be focal or infiltrative too, and can cause enlargement of the optic nerve, which can mimic a tumor, maybe more optic nerve meningioma than glioma. It can cause muscle thickening, mimicking orbital inflammation or thyroid or orbitopathy. And you can see some enhancement in the brain as well. So there's a truly systemic disease. And of course, for all of these, it's a lot of times, especially in your multiple choice questions, it's those beginning clues they give, which may not, I mean, they may not be very specific clues, but just the general situation. So like an older Caucasian person with an orbital mass, I mean, I'm already thinking lymphoma versus metastases, right? Whereas, a young Black female, I would be thinking more sarcoidosis, but it could be orbital inflammation too. It could be thyroid eye disease too. So, just the general demographic and just a few clues can lead you towards a certain path, but you always have to keep an open mind. So this is sarcoid optic neuritis. You can see some inflammation here. I'm not quite sure what they're showing here, maybe the lacrimal gland, but it can be anywhere. And here you have, inflammation around the optic canal as well. Okay, so now let's talk about some useful differential diagnoses. So again, let's review each thing, and then so we have a good idea. So intracornal masses, cavernous hemangioma in an adult. So again, it was nice and round. It's not causing a lot of symptoms except for proptosis, and the main differentials are schwannoma and neurofibroma for a very round, discrete lesion in the orbit. There's lymphangioma here too, but lymphangioma is very different. It happens in children. You get those chocolate cysts. It's more diffuse. The diagnosis is made on imaging, not usually biopsy. You already know it's a lymphangioma, and we often try medication like beta blockers to treat that. So yeah, we didn't have imaging of lymphangioma in this imaging lecture actually, but it's very different from hemangioma, from an adult cavernous hemangioma. Optic nerve glioma, if you remember, there's a childhood form which is more benign, adult form which is very aggressive. This is more fusiform, sort of roundish enlargement. Treatment in children is with chemotherapy, and the main differential is optic nerve meningioma, which is usually in older females, and you get the optociliary shunt vessels. If you think about optociliary shunt vessels, what are the causes? So optic nerve glioma, optic nerve meningioma is like sort of the classic, like you got to watch out for it, but optic nerve glioma, CRVO, BRVO, more rarely CRAO or BRAO, and then of course chronic glaucoma as well. But the main thing that they ask on the boards is that you got to be careful that it's not a meningioma or a glioma. And treatment for optic nerve sheath meningioma is 3D stereotactic radiation, as opposed to sphenoid wing meningioma, which is surgical resection. Optic nerve gliomas are more common in NF1, and about half of patients with optic nerve gliomas have NF1. So schwannoma and neurofibroma, as we discussed, are the main differential of a cavernous hemangioma as a round, as a sort of discrete intraconal mass. And again, the schwannoma, neurofibroma, and the cavernous hemangioma, those three lesions they don't bleed much. They don't have a lot of blood supply, so you can remove them. Metastasis has more sort of diffuse involvement, but it can be focal as well. It can cause symptoms, but it can also be a little bit symptomless. The one that causes restriction and inophthalmos is breast carcinoma that has metastasized. Lymphoproliferative disease or lymphoma. So it's all a spectrum. You can have like sort of benign, so you can have like lymphocytic proliferation, or you can have outright lymphoma. But anyone who you biopsy and it's like lymphoproliferative disease, which is monoclonal, even if it's not frank lymphoma, they need to have a bone marrow biopsy and a workup with an oncologist, because these can lead to lymphoma. But the main difference is that on imaging, you'll see that it's more sort of molding and diffuse. It can involve the lacrimal gland, but it can show up intraconal as well, which is why it's on the differential. Varix and CC fistula are both intra. Their findings are intraconal because it often involves the superior ophthalmic vein. But in general, varix, things will be more quiet because it's a sort of chronic condition with an enlarged superior ophthalmic vein. Whereas a CC fistula, it can be direct or indirect, but the direct one, which is more high flow, causes more symptoms, and is more commonly, it occurs with trauma. That will have a lot more symptoms and have cranial nerve palsies as well. Treatment for a varix is either observation, or you can handle it endovascularly, or you can expose it for the interventional radiologist to inject something that's sclerosing into it. Or they can embolize it from the venous side, and then you can excise it. CC fistula, as we discussed, treatment can be endovascular, both from the arterial side with a stent or from the venous side with coiling. And coiling is usually the first line treatment, as long as it's successful. Hemangiopericytoma is actually a more diffuse, aggressive tumor. That's a vascular tumor, but we didn't have an example of that in the imaging. And of course, fibrous histiocytoma is a more aggressive tumor as well. But we have a whole talk on tumors as well, if you guys are interested. But so these are a lot of your intraconal masses. Extraconal, so metastases often occur extraconally. Lymphoma is actually more common extraconally. So in the lacrimal sac fossa, as we said, 50% of lymphoma in the orbit occurs in the lacrimal gland. Rhabdomyosarcoma occurs more commonly in the superior orbit, which is the embryonal type, but the more aggressive alveolar type can occur inferiorly. Dermoid and epidermoid are sort of the, at least imaging wise, the sort of the extraconal ones that look like cavernous hemangioma or schwannoma, where they're very round and discrete, but you can usually feel them. So these occur at our sutures. So they either occur at the frontozygomatic suture, which is more common, and you'll see that round, sort of very discrete, soft thing, which may or may not be adherent to the bone underneath. In a child, that's a dermoid cyst. However, you can have patients with some other sort of lesion. So I had a young girl who had a lesion that sort of felt like a dermoid cyst, but it wasn't quite in the right place, but it was still near the frontozygomatic suture. But when I exposed it to remove it, first on imaging, even though it's shaped like a dermoid, the differential on imaging was more either a lymph node or a vascular lesion, or they weren't sure what it is. And then when I just confirmed with them that it's low flow and that it won't bleed a lot. But when I opened it up, it sort of looked like a dermoid, but it was bleeding a lot. So I gently resected it and I sent it, and it ended up being a very rare condition, which you guys don't really have to know, but a very rare condition called nodular fasciitis, which can occur in the orbit too. So, but usually anything near the frontozygomatic suture is a dermoid, but they can occur at the frontoethmoid suture too. And you can have lymphangiomas. Infiltrating can be inflammatory, like pseudotumor of the orbit, sarcoidosis, or Wegener. That's the main granulomatous disease you have to think of. Lymphoma, metastasis, cellulitis we discussed before too. It can either be postseptal or preseptal. And the main thing is if the sinuses are involved or not, because that can be dangerous. So you do IV antibiotics. But more sort of benign causes of cellulitis is dactylocystitis can be controlled with oral antibiotics more commonly. And of course, if it's more from a skin infection or a chalazion, that can be easily controlled. So let's just go through leukocoria very briefly, retinoblastoma, total retinal detachment, Coast disease, toxic crisis, you'll discuss elsewhere in your lectures. Retinopathy of prematurity and PHPV, which is now called persistent fetal vasculature, but these are all differentials of leukocoria. So let's go through a few cases. Okay. So let's see what we're seeing here. So the globes are, the globes don't really seem the right shape and they're a bit small, right? But it may be that the cut is not in the right place. So you always have to think like, where's the cut? So here we can see the globe looks good, but look, there's all this like enhancement going on underneath the globe. So what can it be? It can be anything, right? It can be inflammation, lymphoma, metastases, any of that, right? So we have to look at the clinical history. So this was actually basal cell carcinoma. So here you can see it's in the eyelid, and it was sort of going under the globe here. So basal cell carcinoma, squamous cell carcinoma, and sebaceous cell carcinoma. Like if you find them in the orbit, they're not going to start in the orbit, right? They always have to start in the eyelid. But squamous cell can start in the eyelid skin or in the conjunctiva too, whereas basal cell starts in the skin. So it is a malignant tumor, even though it's a semi-malignant. I mean, it's one of the most sort of slow-growing ones, derived of the immature keratocytes and skin appendages. It's more common in in any sun-exposed area, so the face is common. It's slow but invasive. So anytime you see a notch in somebody's eyelid, you have to be worried about basal cell carcinoma, because other things should not cause a notch, like benign lesions. But sometimes significant inflammation can cause a notch too. They're prone to recur, so they rarely metastasize, and of course you can use MRI to use the depth of invasion if it's involving the orbit. Now, what do we do for a basal cell on the margin of the eyelid? Like, you want to do a wedge resection and you want to get around it, but as long as you have some clear histology around it, it's fine. You don't have to go 5 millimeters away or 10 or like whatever it might be. So usually we do a wedge resection. Biopsying something you suspect as a basal cell, it's a little bit tricky to just do a superficial biopsy at the eyelid margin, because well, what if that turns out benign, but the real malignant part was more deep? So I usually like to biopsy and so do an excisional biopsy and cure at the same time. But if it goes into the orbit, then, so in the orbit, we can't really get clear margins. We have to once something's in the orbit, to truly get rid of it, you have to do an exenteration. But now we have other, p53 inhibitors and other oral medication too that can slow down its growth. So in someone who doesn't want that invasive surgery, you can do that too and see if it responds. So here you can see this is enhancing. So there's an enlarged superior ophthalmic vein. So this I would be leaning towards a CC fistula. I mean, it can be a varix too, but they're less common. So here on this, you can see that this is enlargement over here. So this is a bilateral indirect carotid cavernous fistula. Yeah, so you can see that here, this cavernous sinus is, well, this one's enlarged too, so this is both big. So indirect are 10 to 15. So another thing about indirect is you can see that this enlargement is not the same as that other huge enlargement I showed you before, right? So the indirect ones are sort of slow. So they're 10 to 15% of intracranial malformations. And, direct is, of course, the communication between the intracavernous carotid artery and the venous cavernous sinus. The indirect ones are more like sort of the small vasa nervosum and vasa visorum of, the internal carotid and the nerves over there. So the small vessels can start to leak too. So again, trauma was the most commonest cause of the direct, as well as ruptured aneurysm, and other like conditions like Ehlers-Danlos and osteogenesis imperfecta can cause a direct one too if everything runs through. And that's when you get pulsating exophthalmos, bruit, decreased eye movements, glaucoma too, but you have bigger issues than the glaucoma. So those are the ones where you'll see that huge superior ophthalmic vein like we showed in the first slides before this. You can get enlargement of the extraocular muscles, proptosis, and of course the dilated superior ophthalmic vein and conjunctival edema. So there have been a couple of patients I've seen who were admitted for orbital cellulitis because they had all this chemosis and decreased extraocular movements. But when I examined them, there was more chemosis than inflammation, and there was a 6th nerve palsy. That's why she couldn't move her eyes. So orbital cellulitis will not cause a specific 6th nerve palsy. It'll just cause decreased movement all around. So that made me think of CC fistula. And of course, on the scan, they should have seen if the sinuses are full or not. Because if the sinuses are clear, then it's unlikely to be orbital cellulitis. So these are all sort of like differentials of these things. But if you look at every piece of information, the answer usually becomes clear. So here, what can you see here? So the sinuses are clear, lobes are here, but here you see something in the back, right? So if you see this, I mean, if you see a mounded lesion in the back, before anything, you can think, oh, is this a tumor? Is this choroidal thickening? But then there's no lens here. So it's probably a lens that fell, right? Yeah. So it's a right lens dislocation. So on yesterday, so I guess, oh, sorry, there were 3 things. Oh, wait, so let me discuss your question for Adam. So in order of occurrence, okay, so for thyroid eye disease, I would still say, so inferior and medial, for basal cell, sorry. Yeah, so the thing about it, it's probably still inferior, medial, superior, and lateral. The problem with the medial one and basal cell is that you often don't see it, right? So it may not be that you don't recognize it till afterwards. So, I mean, is that why they sometimes feel it's more aggressive? Or is that why they feel that may be more common, but it's not recognized? I'm not sure, but I think for testing purposes, I would, as you know, like, people like me will write some of the questions in the test. So, I mean, they may have their own sort of biases, but I think for tests, probably IMSL is probably still the right thing. Okay, and that's true for the rectal involvement in thyroid as well. All right. So yeah, so speaking of that, so this looks like inferior involvement of a muscle, maybe some enlargement around it. So inflammation around it. I mean, so this could be thyroid eye disease. It could be lymphoma. It could be orbital pseudotumor. On the other hand, it could also be metastasis or Wegener's or, but I would always think of the more common things first. So the most common things we see that enlarge your muscles are usually thyroid eye disease or orbital pseudotumor. And I'd probably say the third thing that I see for extraocular muscles is probably lymphoma, not, sarcoid or not Wegener's, even though, overall, yeah. But orbital tumor or thyroid would be my main differential. And then, let me see. But, there's other clues, right? So, if there's a lot of proptosis, if there's upper eye, so 90% of thyroid patients have eyelid retraction, right? So if that's the case, then I think this is thyroid. I should look for eyelid retraction. And a lot of times, like even the ones that seem to not have eyelid retraction, they're squeezing down their eyelids some. But when you make them follow your finger for eye movements, then they relax and their eyelids retract. So if somebody doesn't have proptosis or eyelid retraction and they have this, and they're inflamed. So a lot of thyroid patients aren't inflamed either. So, a lot of that will give me a clue as to what it is, if it's pseudotumor or thyroid. But then this is my follow-up exam. So this is probably after treatment. And generally speaking, even if you treat thyroid eye disease with steroids, the muscle don't suddenly get smaller. Now, they're saying now with the new treatment of teprotumumab, it can decrease the muscles as well. And it may, but this drastic an improvement, it was probably inflammation. So it was probably pseudotumor of the orbit. Yeah, that's what it probably was. All right. So what's this? So this is, a big tumor-like thing in the area of the lacrimal gland. I don't think it's very discrete. It looks sort of, and this is an MRI, so of course it's more enlarging. And this may be the same thing we saw before. And here you can, but there's like heterogeneous enhancement in there. But see here how it's so irregular, it's probably eroded bone. So I mean, I would guess like adenoid cystic carcinoma or something. Or it can be, one of the skin cancers or something else that's eroded through. So, I don't know, sebaceous cell, squamous cell. Okay, so this is squamous cell that's aggressive and invasive. So no anatomic boundaries. And so the main thing about squamous cell is that it can be painful, and adenoid cystic can too, because they have extension along the perineural sheaths. And, that's how they can get intracranially. So again, treatment for this, you can radiate it, you can resect it, but it's a difficult thing. So here, it's a round, discrete lesion here, very round and discrete. Again, so, so remember our three differentials. So the most common one, cavernous hemangioma, but you can have a schwannoma, which is probably the next most common, and then you can have neurofibroma. So that would be my guess for something like this. And, especially if it's most likely not causing a lot of symptoms except for just proptosis that somebody's noticed. And yeah, this is a cavernous venous malformation, previously known as cavernous hemangioma. Okay. So let's do some questions. So it's 247. Okay. So I don't know, maybe you guys can write it in the chat. Okay, so I got an E. Okay, is there anyone other than Adam? Let me see. Okay, I guess everybody's going with E. Okay, good. All right, excellent. So yeah, so as we discussed, it's not from the differentiated recti, it's from embryonal mesenchyme that is somewhere in the orbital fat. So yes, that's what it was. Okay, so let's see. So this one is always hard to remember. So what is the MRI signal of globe melanotic melanoma typically? So you remember the amelanotic one was sort of intermediate in T1 and T2, but the true melanoma was something in T1 and something in T2. So does anyone remember? Was it high in T1 or low in T1? Okay. Well, anyway, if you remember, so it was high in T1 and low in T2. Okay, so let's see. So what imaging features favors thyroid eye disease over orbital pseudotumor? So, okay, so let's see. I guess painful isn't really an imaging feature. So, but painful, they can both be painful, but pseudotumor will usually be painful. Thyroid eye disease can be either, depending on if it's inflammatory or not. Muscle involvement includes the tendons, right? So no, that's, yeah, good. So yeah, you guys are answering C, which is right. So involving the tendon, I would think pseudotumor. I could also think lymphoma. Sparing is specific more for thyroid eye disease. Of course, frequent lacrimal gland involvement is, so in thyroid eye disease, like your lacrimal gland not going to be involved, but they often do have somewhat larger lacrimal glands, and they also have, like more SOOF and roof. So SOOF is suborbicularis oculi fat, and roof is retroorbicularis ocularis fat. They're both the same sort of fat, but the roof is superior, the SOOF is inferior. But yes, sparing the tendon and thyroid eye disease is the classic thing. Okay. Okay, excellent. So, so this was, all the imaging thing that we had, sort of combined with our radiology colleagues.